Yeah, hello, I'm Eva Kimby, Professor of Hematology in Stockholm, and I'm now in a meeting in Barcelona, the Hematology Malignancy Congress. So I'm very happy to be here with my friends, my lymphoma and myeloma friends. So Bertrand Coiffier is well known for he's a really expert in lymphoma. Also Gilles Salles, the other French expert in lymphoma. And then we have Thanos Dimopoulos from Athens, and he is the myeloma expert in the field. Myself is more like, CLL, a bit myeloma, and mostly indolent lymphoma interested. So we have been now in this meeting, and we found a lot of interesting sessions and a lot of good speakers. So I would like first to go with some questions for you, Thanos, because you had the lead function in the myeloma session, and I understand that you are very excited because there are much new things, new drugs. And what in this meeting do you think was the most interesting?
Yes, Eva, thank you. We had presentations and discussion regarding mainly the four agents with different mechanism of action. So we heard a lot about the novel proteasome inhibitors, about the role of calfizomib, especially right now, since there was just a press release a few days ago regarding the comparison of calfizomib with dexamethasone versus bortezomib with dexamethasone, the Endeavour trial, which showed a very remarkable improvement of PFS in favor of calfizomib dexamethasone.
And that was in relapsing patients?
In relapsing patients, 1 to 3 prior lines of therapy, and the median progression-free survival went from 9 months in the bortezomib dexamethasone arm to 18 months in the calfizomib dexamethasone arm. So these data are really exciting. And also we discussed the role of ixazomib, another oral proteasome inhibitor, which can be combined with lenalidomide and dexamethasone. And also a month ago there was another press release regarding the activity of this combination in patients with relapsed myeloma. And finally, we discussed also the role of oprozomib, which is a quite active oral proteasome inhibitor, but with some gastrointestinal toxicity, and this is why it is lagging behind the development. Also, we discussed the role of pomalidomide and low-dose dexamethasone in the treatment of patients with far advanced myeloma. And there are confirmatory studies which indicate that indeed this combination may be active in approximately 30% of patients with myeloma. And also there are combinations that use pomalidomide and low-dose dexamethasone as a backbone with the addition of calfizomib, or with pomalidomide, or with bortezomib. Then there were some new data regarding the role of panobinostat, a histone deacetylase inhibitor, in combination with bortezomib and dexamethasone. The Panorama trial, which has been reported a year ago, but very recently we had the approval of the FDA of the combination of panobinostat with bortezomib and dexamethasone in patients with relapsed myeloma who had been previously exposed to bortezomib.
But not yet in EMA? It's only yet. FDA, yes.
Yes, FDA, yes. And finally, but not lastly, we heard a lot about an exciting class of agents in the field of myeloma, the monoclonal antibodies. In the myeloma field, we have been waiting for many, many years to get a rituximab-like monoclonal antibody, and it looks like that the anti-CD38 monoclonal antibodies may be indeed a kind of rituximab for myeloma. These antibodies, they have single-agent activity in 30 to 40% of patients with pretreated myeloma, and when combined with other agents, with lenalidomide dexamethasone or with proteasome inhibitors, this activity increases remarkably, and already there are trials that have been completed accrual in the relapse setting, and trials with daratumumab and with the Sanofi compound, which are about to start in the frontline setting. Also, we have elotuzumab, the anti-CS1 monoclonal antibody, and again, there will be data presented at ASCO regarding the benefit of adding elotuzumab to lenalidomide dexamethasone in the relapse setting. Thus, if at this point we have many options for the treatment of patients with relapsed myeloma, for the treatment of patients with relapsed and refractory myeloma, and of course these novel combinations are moving very fast in the frontline setting, which again is being treated according to the age and to the comorbid conditions of the patients. So younger patients, fit patients are getting induction therapy followed by high dose therapy and autologous stem cell transplantation. There are questions regarding the role of consolidation, the role of maintenance in myeloma, and there is an active investigation in this field. For older patients, already we have the bortezomib-based combinations, fixed duration treatment combinations, but also we got very recently the approval from the FDA for the continuous treatment of older non-transplant eligible patients with myeloma with a combination of lenalidomide and dexamethasone, and this is another approach to treat older patients with myeloma. Thus,
could I just ask you, because we also discussed, risk stratification. Are there any trial with risk stratification? I'm thinking of the, the genetic features, which was discussed also in the meeting.
Absolutely, you're right. I mean, we know today that we can identify patients with high-risk myeloma, approximately 20% of the patients who may present with features of extramedullary disease, high LDH, advanced ISS, or 17p deletion or 414 translocation. And also there is active research in an attempt to try to identify also gene expression profiling based risk prognostication in myeloma. However, at this point, we are not at a phase to design treatment according to the risk of the disease. All these data are being collected in prospective randomized trials, and clearly we need to improve the treatment of patients with high-risk myeloma.
But there are some stratification already now?
Patients are being stratified according to presence or absence, for example, of some of these high-risk features, but they cannot be used yet as predictive variables to decide on treatment.
Because that is so important, the predictive variables, really, because you have so many treatment options now.
Absolutely.
So that is so important. And is that the same for the lymphoma, Jill? That you have some, predictive markers when to use the R-CHOP?
I think if we compare the lymphoma field to the other fields that we discussed during this meeting, I think we are a little bit lagging behind. I mean, there is a lot of new things regarding the understanding of the biology of both indolent diseases and aggressive diseases. But it's hard at this time to decide for risk classification. I think what was important and discussed during this meeting regarding diffuse large B-cell lymphoma, maybe I had that to Bertrand, was the possibility to develop clinical trials for diffuse large B-cell that may potentially target some specific subtypes of DLBCL.
Yes, it's true. What is certain now is that there are a large group of patients for which R-CHOP is the standard, and is associated with very good results and long survival. But behind that, there are another group of patients where the response rate is low and the progression during treatment is high, with a lot of relapses and short survival. And we don't know all the definition of this patient, but a large group of them is represented by what we call the double hit lymphoma, or double protein expressing lymphoma. Double hit lymphoma are patients with a mutation of c-MYC and BCL2, and these patients with these two hits have a very poor survival, a very poor response rate to treatment, and early deaths, most of them dying during the first year or first 18 months after the diagnosis. But there are also another group of patients that without the genetic modification, but the protein expression. And it's something new that appeared during the last 2 years. These patients that have high expression of c-MYC or BCL2 by immunohistochemistry have also a poor survival. Double hit patients have a worse survival at all, but this one have not a good survival and do not respond very well to R-CHOP 2. So certainly we have defined here a group of patients where we need to find a new regimen that may work very well, like R-CHOP, but clearly R-CHOP is not a good standard for this patient, and certainly in the future we need to develop a randomized study testing different regimens in these patients that have a poor survival. And another message from this meeting is that certainly there is no correlation between the clinical presentation, the histologic presentation, and these double hit or double protein expression patients. So these two tests, the FISH analysis for MYC and BCL2, and also the immunohistochemistry for MYC and BCL2, should be done to all patients with diffuse large B-cell lymphoma, whatever the presentation, whatever the histology.
Because before, many used to do the MYC with FISH if the Ki-67 was very high. But today, you say we should do it in every patient.
Every patient.
Regardless.
There is not, with large series, there is no relationship between the Ki-67 percentage and the expression of MYC or BCL2. And what is important also is not the double expression or the double hit. When you have only one abnormality, it is not so bad. So clearly what is worse is the fact that these patients have the double expression or the double abnormal mutation.
And what would be the treatment that you would recommend today for these patients?
There is not really prospective studies. There is only retrospective analysis. And in the US, there are some studies on very few patients that seems to show that those adjusted EPOC plus rituximab do a little better than R-CHOP, but this has to be confirmed by prospective studies. There are other possibilities, including the new drugs that have been developed in follicular lymphoma, like the different inhibitors, BCR inhibitors, PI3 kinase inhibitor, ABT199, BCL2 inhibitors, and also some new agents that begin to occur that target c-MYC or c-MYC pathway that may be associated with R-CHOP or another regimen.
Lenalidomide doesn't have a role in this?
There are two ongoing studies trying to look at the role of R² plus CHOP. It's difficult to say for the moment.
I think we heard something interesting when summarizing the data about the double protein expression of MYC BCL2, which was the fact that this is mostly encountered in elderly patient, and mostly in patients with the so-called ABC subtype of diffuse large B-cell. And this patient with ABC subtype, there are a couple of trials right now assessing the possibility to add something to R-CHOP, whether it's bortezomib in 3 or 4 randomized trials, lenalidomide. There are 4 trials testing lenalidomide either in combination with R-CHOP or as maintenance, or even ibrutinib now. So there have been trials that started or were designed 2-3 years ago based essentially on GCB, non-GCB. It's possible that the non-GCB may potentially overlap with some of these double protein, and we have to follow that. There was an interesting discussion regarding also still the potential role of alternative therapy, such as dose-adjusted EPO, KCVBP, or for this double hit, more Burkitt-like regimen.
And what is important also is the fact that the double hit, the true double hit, are seen in GCB patients. That is the good risk patient, but some of them are not so good risk.
So you think that the ABC and GC is not so important? It's more important to look for this MYC and BCL2 both on the protein and fish.
These protein expression abnormalities or mutation abnormalities are more important than cell of origin. But there is some overlap between the two. That's probably the reason we have found before that ABC subtypes is worse because they express a lot of these patients, 1/3 of these patients have double protein expression.
One thing also which I noted was that the risk for CNS disease was higher if you have this c-MYC protein expression.
Yes.
So that is also, of course,
another
a risk
in
factor
this patient. It's certainly interesting to do a prophylaxis treatment at diagnosis.
And this is a rather big group now when you look at the protein expression.
Yes, the double hit lymphoma that is seen in GCB is a small group. It's probably less than 10% of the GCB patients. But the double protein expression is a large group. It's 30% of the non-GCB.
If we move a little bit back to indolent diseases, we had nice discussions during this meeting regarding still the optimal management of frontline patients. I think we had discussion whether we should treat immediately patients that were diagnosed.
Especially the follicular lymphoma.
Yes, which coming back to the indolent and to the follicular. And I think that reviewing all the corpus of data, I think there was an agreement that, well, one size don't fit all, and there are clearly a group of patients that can be selected so far only on clinical grounds rather than biological grounds, but there are groups of patients in which watch and wait remained an option, even with the spectrum of tools that we have in first line, which is rituximab single agent or bendamustine rituximab, which seems to be better tolerated and probably as efficient as, or more efficient potentially than R-CHOP. So there was a good discussion regarding the fact that we can individualize the treatment of these patients. Although we also discussed, and we're part of that, the discussion about the grade 3 follicular lymphoma, clearly stating that for this group of patients, although we have left grade apart for some years, it felt that most of the experts agreed that those patients will probably be better managed with classical R-CHOP rather than with Arbenda or other agent because of the particular outcome of this patient. We discussed also during this meeting the role of new agents, antibody drug conjugates, lenalidomide, and the combination of lenalidomide plus rituximab with the interesting result of the R-square regimen, which has been evaluated in a randomized fashion both against rituximab in the Nordic and Swiss study where you were involved, and also against chemotherapy in the relevance trial. And I think we will be awaiting more mature result of these trials. But also some new agents that target the intracellular pathway. And I think we have 3 exciting agents in the field that actually cross a little bit indolent lymphoma and CLL. Maybe to present them in indolent lymphoma, we have the BTK inhibitors, the PI3 kinase inhibitor, and the inhibitor of the BCL2. Probably the most developed right now are the PI3 kinase inhibitors, which have really been evaluated in many patients as a single agent.
And it's now approved also.
Yes, this drug has been approved based on studies that evaluated this agent in patients that were refractory to both alkylating agent of rituximab, given an about 55-57% response rate that lasted 1 year. We still have to learn how to use this agent because there are some toxicity profiles which are particular, especially the GI related effect with some colitis, so that needs to be assessed. Ibrutinib in indolent diseases is probably not well advanced, and the other BTK inhibitors are still being evaluated. It has clearly a role in the management of mantle cell, and we do think that the field will be evolving pretty soon in mantle cell. We're expecting the result of the large SHINE study, which compared bendamustine rituximab versus bendamustine rituximab and ibrutinib. And I think the BCL2 inhibitors are mostly developed in CLL. There are also some antibodies that are being developed, I mean antibody drug conjugate, but also analog of CD20. And within these analogs of CD20, obinutuzumab is probably the more well advanced, has proven some efficacy in CLL. We had heard a press release quite recently in the field of patients with follicular lymphomas that were previously refractory to rituximab, and the study, which I guess will be presented in the next few months, but was just alluded to during this meeting, was the fact that in those patients that were refractory to rituximab and treated with bendamustine, the addition of obinutuzumab to bendamustine led to a significant improvement of progression-free survival. We have to see the whole data set, but I think that's a signal that this drug, which has proven to be interesting in CLL, may be also interesting in lymphoma. But what did you find about the CLL presentation during this meeting?
First, I just want to focus on the transformed follicular lymphoma, just a few words about that, because I think that is important, that people are aware of the transformation. So, but then I could go, because that is also relevant for the CLL, the Richter transformation.
Sure. I think with this indolent disease, we do know that some genetic mechanisms, which are still not always well delineated and understood, but led to accumulation of genetic events and transformation to a high-grade disease. This is clearly a turning point in the history of lymphoma, follicular lymphoma, and other indolent. It can be diagnosed by clinical suspicion, but I think sometimes without clinical suspicion it does appear, and that's probably also a signal to try to rebiopsy patients that relapse, because sometimes you discover a transformation even without no sign. The optimal treatment of these patients still remains to be defined. Usually they are treated with anthracycline-based regimen and rituximab, and clearly the outcome of these patients have improved over the years. Younger patients may be a good candidate for intensive therapy such as transplant. It's probably quite similar to the situation we do see in CLL, although Richter syndrome is still very severe, quite dismal outcome.
And also with the new drugs. For in the CLL session, of course, we discussed a lot about the new drugs. But the main message is, of course, that still FCR is a treatment, and that is the treatment of choice for young patients with a disease which is requiring treatment, as long as they don't have the P53 deletion or mutation. So that should be tested in every CLL patient, because then FCR is not a good option. But for the patient, for example, with a mutated variable gene, immunoglobulin gene, they have a very good survival and also progression-free survival out 10 years. That has been shown both from the MD Anderson and from the German group. So that is still a patient group who had the now old-fashioned FCR treatment.
Do you think we can cure those patients?
Oh, I don't know if they are cured, but I don't think they are cured, but they have still, minimal residual disease negativity out 10 years, some of them. So that is both from the German group and also Michael Keating. So that is a good thing, But, of course, you have to follow them closely, and some now are thinking of to follow MRD also to find the relapse early, especially if they have now a new mutation, because the clonal evolution in CLL is now something which is really followed in many patients. So, and I think that the reason why the indolent lymphoma and myeloma have more of these genetic markers is, of course, that we can follow them in the bone marrow for myeloma, but for CLL we have the blood, and we could follow the clone in blood, although the proliferative centers for the disease, where something is really happening, is in the lymph nodes or the bone marrow and the spleen. But still, we could follow the clone, and that is important.
Yes, one of the things that was discussed about p53 was the fact that it is a prognostic indicator at time of treatment, not at diagnosis.
No.
And you may have some patient with the mutation at diagnosis with a very low evolution until the progression, and at this time you need to treat them differently.
Yeah, yeah.
But
And also it has been discussed, you know, that you could also buy treatment, select for that clone, because there are many subclones and some will respond, for example, to FCR, but the small clone with 17p deletion, they will then grow, because there is a balance between subclones, because that has been discussed a lot, the microenvironment, the role of microenvironment, the macrophages and everything, you know, in the microenvironment is so important, and different clones could react differently.
We have seen and heard a lot about new agents in CLL. What do you think are the most exciting ones at the present time?
Of course, I can't really say if the ibrutinib or idelalisib is the most exciting. Personally, I think ABT199, venetoclax, I think it's the name now, venetoclax, that is more interesting, because that has a single drug shown CRs, and also like MRD negative CRs in patients in relapse. But with the other two drugs, they have good remissions, but no complete remission. Even if you treat the patient as first line, there are very few complete remissions, just a very few.
ABT199 or GDC199, I mean the venetoclax, is actually being developed in all B-cell malignancies. The issues is that although as a single agent it has some marked activity in CLL, this drug will probably need to be combined with other agents, and I think the feasibility of this combination still remains to be determined. There are some very preliminary data suggesting some feasibility with classical drugs in B-cell malignancies, but we probably need still to work on and to determine the optimal dose and schedule when combined with bendamustine or with classical agents. I mean,
there are ongoing trials with all the drugs with like BR, because people, you know, even if you have a good response, but if you don't attain a complete remission, you are always nervous that something will happen, and that is the one with the Richter transformation, for example, because there are a lot of Richter transformation. It might be, of course, that it's early on, so they have already had the alkylating agents, the fludarabine, and they are prone to the transformation. But still, there are some data that ibrutinib might be, you know, it's also with the BTK inhibitor. The cell might use other signaling pathways, and that is also what has been discussed a lot. If the patient are progressing on ibrutinib, this is a bad sign, of course, for the patient, and you should not take out the drug and wait and think what to do next. You should decide what to do next, and after you have decided, you put away the drug. Otherwise, they got like a flare. We have seen patients, for example, who have been, you know, on a weekend or some extra days holiday. They didn't bring the drug, and the lymph nodes came back. So that is a very, very effective drug. But also, you know, you have to go on, keep on.
So we are facing very exciting times.
Yeah, really. I think we have been discussing some of the subjects, and yes, we go on with this meeting. Thank you.
Thank you.
Thank you.
Thank you very much, all three of you.